Good morning, everybody. This is Susan Connor from the Early Intervention Training Program, and I'm happy to welcome you to this morning's winter webinar on the topic of X chromosome disorders, presentation and developmental implications in the early years. We are really pleased that you were able to join us this morning. One note, because there was some conversation about it on the chat, I just wanted to confirm that we did need to reschedule. So this afternoon's winter webinar, which was on the topic of early identification of autism, was canceled. An email was sent out to everyone who was registered, and we have rescheduled that webinar to March 11th at 1:30. So anyone who was registered for this afternoon's webinar was automatically registered for the March 11th date. If you weren't registered but now can join the March 11th date, please feel free just to visit the training program website and go ahead and register for it. We're still accepting registrations. So it's great to see some familiar names on our webinar today and also some new folks. We're pleased to have with us today as presenters Dr. Kathleen Kastner, who is a developmental and behavioral pediatrician with the University of Chicago, as well as Melissa Zolecki, who is a nurse as well as a mom to a child with Fragile X. So we're pleased that they'll be with us today. As usual, you have your facilitators for the today who will just make sure that everything goes as smoothly as possible. Maria Maddox, who you heard earlier, as well as myself, Susan Connor.
My name is Katie Kastner, and I am a fellow in developmental behavioral pediatrics. So I'm excited to be with you guys this morning. So we're going to start off by just reviewing some basics of a little bit of genetics. Some of this may be review for some folks, but both of the disorders that we're going to focus on today have a pretty clearly defined genetic basis, so we want to make sure we're all on the same page when we're talking about the language of these disorders. So if you remember way back when to your biology classes, our DNA is made up of a series of base pairs, so two different molecules connected to each other in a kind of string of these base pairs. They wrap around each other and form that double helix that you've seen and heard of so many times in the past is what we think of as being DNA. And so that double helix wraps around itself, and then when you get to the place of being kind of wound really tightly, there's actually small proteins called histones that I'm pointing out here on the screen that allow the DNA to wrap around even further. And the end result of this process of wrapping, you end up with a really tightly wound structure of DNA called a chromosome. So the chromosome has kind of a similar structure in all of the chromosomes, where you have a short end called the P arm, a longer end called the Q arm, and then in the middle you have a centromere. So each chromosome is made up of this large amount of DNA wound around really tightly into a compact little bundle.
Okay, Katie, I'm going to interrupt you here for just a second. I'm going to ask you to turn your volume up, and how you do that is right above that talk button is a slide bar. If you would just slide that off to your right a little bit more.
Okay, how about this? Is that better?
Maybe down just a bit, just a little.
Okay.
Okay, I think that works great. Okay, sorry for the interruption.
Okay. Do you need me to repeat the last slide, or you think folks heard?
I think they heard.
Okay, so on this slide, what we're seeing here is now the typical makeup of human chromosomes. So people have 22 pairs of chromosomes, and then what are called the sex chromosomes. In women, we have 2 X chromosomes, and then we'll have an X chromosome and a Y chromosome. And so the disorders that we're going to talk about today result when there is an issue with the X chromosome. Again, women have 2 copies of those typically, and men have 1. And both of the disorders we're going to talk about impact this chromosome here. So the first disorder that we're going to focus on today is called Fragile X syndrome. So Fragile X syndrome is an X chromosome disorder. It results from a mutation in a gene found down towards the bottom of the X chromosome. We'll get into a little bit more detail about the underlying process of that, but the gene that's impacted is called Fmr1 gene. And this gene mutation results when there's extra copies of those base pairs within that gene. So like we talked about, DNA is made up of these sequence of base pairs bonded to each other, and in Fragile X syndrome, there are extra numbers of those base pairs within this particular gene. As we discussed, women have 2 copies of their X chromosome and men typically have 1. And so Fragile X syndrome, the inheritance of it is different in men and women. And it'll be important to think about kind of how the X chromosome is passed on from mother or father, depending on the child. And so we will dive into a little bit more detail of that. But the big picture of what happens in Fragile X is that you have a mutation in this gene because you have extra numbers of those base pairs. And when you have extra numbers of those base pairs, you actually shut off that gene, the Fmr1 gene. It no longer is active, and so there's a protein that's then missing in the brains of children who have Fragile X syndrome, or it's present in decreased amounts, called FMRP. And again, we'll go into a little bit more detail, but that's the big picture. So I'm going to hand it over to Melissa. She's going to talk about this slide for a minute.
Hello, everyone. Thanks so much for joining us. As they mentioned before, I am a mom of a nearly 14-year-old son with Fragile X. My professional background is a nurse as well, so I have a little more understanding, I guess, of some of this. So when we talk about Fragile X inheritance, every person inherits a gene from their parent, or either an X or a Y from their dad. And they can only get an X from their mom. So when you see in the chart here, this is how it can happen. So female full mutation, meaning they have shut off that Fmr1 gene, have a 50-50 chance of passing on that full mutation to their children. I am what's called a premutation carrier, so that gene is not shut off, but I do have a higher level of repeats, which we will discuss that in a little bit as well. I, as well, have a 50-50 chance of passing on the Fragile X premutation to any of my children. However, it can expand to become the full mutation, is how I have my son. You can pass on the premutation as well. Male full mutations would only pass on the premutation. I think this is really interesting. To their daughters. They would not pass on that full mutation if they happen to have children. Their sons would be unaffected, but their daughters would have the premutation. But premutation males can pass on that premutation 100% of the time to their daughters, but their sons would be unaffected. I just want to talk a little bit next here about that Fragile X. That gene is actually responsible for a family of disorders. It is not only, when we talk here, people always talk only about Fragile X syndrome. And Fragile X syndrome is what kind of everybody knows. It's where you see the biggest issues. But as time has gone along, especially since our diagnosis 14 years ago, there's been a lot more seen that there are carrier-associated disorders, and we'll get into those a little bit deeper a little bit later, but the FAXPOI is called Fragile X-associated premature ovarian insufficiency, and then there's also FAXTAS, which is Fragile X-associated tremor and ataxia syndrome. And we'll talk a little bit more about those, but then you also have the Fragile X syndrome. So the Fmr1 gene is responsible for regulating the production of the FMRP, as Katie had talked about. So this protein is instrumental in brain development. So in the absence of this protein, trying to learn and build those strong connections in your brain is significantly challenged. That protein works as a breaker, a regulator, within the brain. So without that protein, some of these processes can go haywire, and that's where you start to see some of the manifestations and the clinical symptoms of someone with the full mutation Fragile X syndrome. They're also finding that even with the premutation, that they are having some defect with the protein is not regulating appropriately, and that's why you're seeing some of these other carrier-associated disorders, like I said, the FACS-SAS and the FACS-POI. So now we're going to talk about the prevalence of this. 1 million people in the U.S. are at risk for developing a Fragile X-related disorder. Now, for a lot of people, whenever I tell them that my son has Fragile X, the response I get is a deer in headlights and a fragile what kind of question, because most people have not heard about it. And when you think about that fact that over 1 million people in the U.S. are at risk for developing a Fragile X-related disorder, it's a lot more prominent than most realize. We talk about premutation carriers. So the estimated number is that 1 in every 151, and this is a CDC number, females are carriers of Fragile X. Most don't know it until they have a child that is diagnosed with Fragile X. And we'll talk about my story, how I found out about it. And it's estimated that 1 in every 468 males are premutation carriers. The gray zone, this is really something that's kind of on the cusp of where research is moving. They're saying that this gray zone is where your gene is not necessarily normal in that repeat level, but you're not reaching the premutation state. So 1 in every 35 females and 1 in every 42 males. So there's a lot of research that's being done on that. The full mutation, the numbers currently are 1 in every 3,600 males are believed to have the full mutation of Fragile X, and 1 in every 4,000 females. About 30% of those that are diagnosed with Fragile X also have a dual diagnosis of autism. A lot of families that I have worked with have reported that, you know, their initial diagnosis was autism, but then they just didn't quite fit the criteria and ended up following up and finding out that they have Fragile X, and some then still remain having a dual diagnosis of autism.
Melissa, there was a question that seemed like it might be appropriate to ask right here, and the question had to do with can a synthetic version of the protein be given to a child?
At this time, although they know the makeup of the protein, there is not a way to get that protein into the brain into a functional use. There's been a lot of medication trials that have been done as of the last few years that kind of work earlier or in the process to kind of control some of these other parts of the brain, the GABA system and things like that, that the FMRP is instrumental in regulating. So they're trying to block down some of the overactivity that occurs in the absence of the protein, but there is not a way to supplement that protein at this time.
Okay. And one other question that seems to fit really well here, since we're talking about genetics. Debbie was kind of curious, is the Fragile X just on one chromosome or on all of them? And kind of to go along with it, does it need to be passed on by both parents or just the mother? Is it guaranteed if it's been passed on?
It does not need to be both parents. It can be only one parent. And it's a 50-50 chance. So I have a good X and I have a bad X, if you want to look at it this way. So each time I had a child, I had a 50-50 risk of passing on that affected X or the non-affected X. Now, what happens at conception is whether it would expand to have a child with a full mutation versus would I pass it on in the premutation state isn't necessarily a guarantee. We could get more in depth with genetics, but I think kind of leaving it at that time, leaving it there. So it doesn't need to be both. It can be passed on by one. Like I said, fathers who are premutations only pass it to their daughters. Their sons would not be affected because they give their sons a Y. And it's not a guarantee that as a mother, I would give it either. You have a 50-50 chance.
All right, thanks. So it looks like we have a poll here, and the question that goes out to everyone is, does Fragile X syndrome, Fragile X syndrome is the second most common cause of inherited intellectual disability. Yes or no? Is it the second most common cause? So to open up your poll and indicate whether or not you should have a yes or no choice there, whether you think yes, it is the second most cause of an inherited intellectual disability, or no, it is not the second most common cause. We'll give folks a few more seconds to respond here. Right. Still getting responses in, so great. All right, let's see how you all responded. So our poll here shows that looks like 63% of you said that you thought that no, it is not the second most common cause. And it looks like, Melissa, I'm going to let you respond to that, or Katie, whoever it is who's doing this one, and we'll see how you answered that as well.
Yeah, thank you. So actually, Fragile X syndrome is the #1 most common cause of inherited intellectual disability. As Melissa was talking about when we were discussing the prevalence, the numbers are quite high, and it is something that impacts a lot of folks. And the research has shown that it's the most common cause of inherited intellectual disability. We're going to touch a little bit more on the relationship between Fragile X syndrome and autism later, but just to say at this point, when we kind of look at all comers children who have been given the diagnosis of autism, it is the leading genetic cause found in those children. So really important to think about, and something that affects a lot of folks. So we're actually going to go ahead and switch gears to the other syndrome that we're going to talk about today, other X chromosome disorder, and that is Turner syndrome. So we're going to touch briefly on the genetics of that syndrome as well. So as we were discussing with Fragile X syndrome, everybody's got 22 copies of their what are called autosomes, or the numbered chromosomes, and then their sex chromosomes. And what actually happens in Turner syndrome is, instead of having 2 X chromosomes like we typically see in women, or 1 X and 1 Y like we typically see in men, people who have Turner syndrome actually just have 1 X chromosome. So they are missing the second sex chromosome, either X or Y. And what we're seeing here is what I call the karyotype. A karyotype is when we look at the makeup of the chromosomes in someone's cells. And so on this picture you can see here, they've been numbered for us. There's 22 pairs, and then we get down to the sex chromosomes. There's 1 X, and we're missing either the second X or the Y chromosome. And that's what we call Turner syndrome. So Turner syndrome, in terms of its frequency or prevalence, is relatively common as well. It affects approximately 1 in every 2,000 to 2,500 live-born female newborns. The numbers of prevalence in Turner syndrome in pregnancy is actually higher because there can be cases of Turner syndrome where the baby will miscarry during pregnancy, depending upon the severity of some of the complications that we're going to talk about a little bit later. So the kind of underlying difference here is not that we're missing or not that we have a mutated gene in particular, like in Fragile X, where there's 1 gene that's been identified as being mutated, but actually the whole chromosome is missing. And the way that this happens in terms of inheritance is, as we were discussing with Fragile X, at the time of conception, the embryo receives 1 chromosome from mom and 1 chromosome from dad, typically of each pair. But if we focus in on those sex chromosomes, in this case, they'll get 1 X chromosome from mom or dad, or excuse me, from mom, but then be missing the second chromosome from dad. It can happen at the time of splitting in the egg in mom or in dad, or it can happen a little bit later, which can give a bit different of a presentation because you may have some cells that are missing the chromosome and some cells that are not. But basically at the time of fertilization, there's an error in terms of the distribution of the chromosomes, and you end up missing that chromosome. And again, we'll dive a little bit more into the details of how that presents, but just for the kind of genetic basis of Turner syndrome, you can think of it as being a missing X chromosome or Y chromosome. Because the Y chromosome, the presence of the Y chromosome gives our phenotypic expression of being a male. These children are female. So even missing the second X chromosome, they will have the phenotypic expression of looking and appearing to be a female, because the Y chromosome is what confers the kind of characteristics of being a male at its most basic level. All right, so now we're going to dive into a little bit more detail about how the diagnosis of both of these disorders are made. And Melissa is going to start by telling us a little bit about their story in terms of their journey with diagnosis.
All right, so in my family, once we received the diagnosis, we were able to actually kind of look back and identify it within four generations of my family. And as I talked about before, the inheritance pattern is 50-50. In my family, when we look at those that were at risk to have gotten this, about 70% of those that are at risk are either having the pre or the full mutation. Several of my family members are still untested that are at risk, but we don't know. They're not exhibiting signs of having the full mutation, but could certainly be premutation carriers like myself. My sister was the first one that kind of uncovered it in our family. She had a son that was diagnosed back in 1997. I was engaged to be married. She said, "You need to be tested." And subsequently, upon her son being identified, several family members who had children much older than hers were then eventually diagnosed as having Fragile X syndrome. They never had really had an official diagnosis, just been developmentally delayed, and like I said, it kind of cascaded, and now we have 70% of those that were at risk actually have that. I was diagnosed as a premutation carrier 6 months before I got married. Told my husband that if he didn't want to marry me because we were not having kids, he didn't have to. He laughed and said that's not why he was marrying me. But as you can see, that story transcended a little bit because I do have a child with Fragile X. But it was simply from one child being diagnosed that our entire family has then uncovered this. And that's kind of a very typical story, how families find it. One family member gets a diagnosis and then they spread the word and everybody finds out.
So when we think about making a diagnosis of Fragile X syndrome, we order a blood test, and the child's cells are then examined to look for this particular gene. And what they're actually looking for is the number of repeats of those base pairs that we talked about. So when you get the results back, it will have a number of repeats that have been counted on that gene. And as we've alluded to a little bit, you can have kind of a normal number of repeats, which then gives you production of FMRP. And then when you get over to the full mutation, where you have too many extra copies of those base pairs in the gene is shut off and you don't get the production of the protein. So we actually, the results will show you the number of repeats that the child or the patient has on their Fmr1 gene. The premutation is considered if you have 55 to 200 repeats. A full mutation is going to be over 200. And the gray zone that Melissa alluded to earlier is if you're going to have 45 to 54 of those repeats on that gene. And then normal is considered 6 to 45 repeats. So when the child goes and gets the blood test, they'll actually get the results with a number of repeats. This process here of methylation that's kind of illustrated on this graph, these little molecules here, those are methyl groups. And what happens is that when you have too many of the repeats, you actually methylate the gene. which shuts off the gene. So the process of shutting down the gene is the result of these methyl groups being placed onto the gene itself.
So our diagnosis came a little different than we anticipated. As I mentioned, I found out 6 months before we got married that I was a carrier, and this might not sit well with people, but I had seen the family members and all the struggles they were having, and I just wasn't comfortable knowingly potentially giving this to a child and setting them up for a life of challenges. That didn't sit well with me my whole life. I thought I was going to have children. We talked about adoption, things like that, and I just happened to come across a physician who said to me, there's this new technology where they can help you get pregnant and not have you pass on this genetic disorder. I looked into it. The nurse that I was, I did a lot of research, looking at their research, trying to understand that. And with a lot of consideration, my husband and I decided to move forward. And it's a process that's much more common now. It's called pre-implantation genetic diagnosis. And they do test your eggs, and then they can actually test the embryo once fertilized as well. And we did that. Now, mind you, this was 15 years ago when we did that. Science has come a long way since then. And when we talked about earlier the associated disorder, premutation carrier females tend to have difficulty getting pregnant, don't make good eggs, things like that. I was very fortunate that I achieved pregnancy rather easily when we went through this process. I got pregnant on the first try. We were told that we had 3 unaffected embryos. I could get into a whole talk about this story, but basically the physician did not tell us that one of those embryos had a questionable diagnosis. We did not know that. We tested when he was born on cord blood, and I found out when he was 12 days old that he in fact had the full mutation. We tested him a couple other times just to make sure that that was not an error. My emotions were just all over the place. I was a new mom trying to, do that, being told that what we thought we had avoided was actually what he had. I was angry. I was embarrassed at myself. I was so guilty. It was it was a really, really difficult time. I actually called early intervention before I was even able to tell my dad, because I knew that what he needed was support. And it was support that I was not able to give. And honestly, I think there were professionals that were already working with him long before I was comfortable in telling our family. We actually were very fortunate. He did not miss any milestones. We were getting developmental evaluations every 4 to 6 weeks. He didn't start missing things until about the 18 to 24 month range, when language should have exploded, but he did not. I was also then pregnant with his sister, I was due with her on his 2nd birthday. And so when she was born, we really hit it hard with the early intervention, started with speech and OT and things like that. So I know some of you have asked about, who should be tested and how did I know, or who should be doing this. So I said we'll cover it. Here we go. So when I do my work in the Fragile X world with families and professionals and things that I do, and mind you, I'm 100% volunteer when I do this. This is my passion because I want people to know, and I want these kids to get what they need and they deserve. Everyone actually, diagnosed with an autism spectrum disorder should be tested via a blood test for Fragile X. I want to kind of give a little caveat to this. A lot of times when I encounter people and they say that their child has autism, oh, they were tested, they had that genetics workup. And I ask them, were you specifically tested for Fragile X? Because there is a microarray that is a panel that covers a wide variety, I believe it's 64 different tests. And it does not include Fragile X. Fragile X DNA analysis needs to be a separately ordered test. It is not part of that panel at this time. Females with unexplained infertility, premature menopause must be tested, especially before undergoing any sort of infertility treatments. You know, I said when we went through this 15 years ago, the infertility office that was helping us do this was not commonly testing their patients for Fragile X. After I got a hold of them, they started to. Even in my regular obstetric and gynecology office, they were not commonly screening patients for this. When they would come in, again, I got a hold of them. They now do that as well. Anyone who has a family member, an adult, who has symptoms of FAXTAS, and I will talk about that a little bit more later. But again, sometimes it's these pieces of the puzzle. You have a child that has a delay, you had mom that had a hard time getting pregnant, and then you have grandpa that has this kind of FAXTAS, which is like a mix between Parkinson's and dementia and things like that. You kind of start putting these pieces together and you realize that this is all related. Obviously, if you have a family history of Fragile X, testing is recommended. And then families with multiple members with intellectual disabilities should consider Fragile X. When my sister was having difficulties getting pregnant, they did ask her about this. And again, her son is even older than mine. And they mentioned that there were some cousins who had delays. And at that time, this was 20 years ago, that was not of concern. Today, as things have moved forward with awareness, that would certainly cause concern. I put this picture on here. I think that part of the thing of this is supporting families. The picture that's on here now, this is a group of leaders like myself from all throughout the United States who most of them did not know they were carriers until they had a child diagnosed. Most of them, their journey to diagnosis was not smooth. It was very difficult, and they got a lot of runaround. And once they actually received that diagnosis of Fragile X, actually felt a sense of relief because then they finally knew what it was.
All right, so now we're going to switch gears again and talk a little bit about Turner syndrome and the process of diagnosing that. So as we mentioned earlier, this is a blood test as well, typically in a child who you have concerns about Turner syndrome. And so the process involves getting what's called a karyotype from the blood test. So the cells are broken apart and the chromosomes are kind of processed and removed so that you can look at them under a microscope. And then they're arranged by pairs to figure out how many of each chromosome are present. And then you're just looking to see if you're missing that second X chromosome in the girl who's affected by Turner syndrome. The part about diagnosing Turner syndrome that gets a little more complicated is, so number one, this is something that can be identified prenatally. Sometimes is when there are concerning findings found on ultrasound, which we'll talk about, and so then that process might involve diagnosing based on an amniocentesis during pregnancy. Additionally, the process of finding the correct number of cells to kind of look in, if you're looking for Turner syndrome, is complicated at times because it may not be present in every cell. We'll talk a little bit more detail about that down the road, but important to know that, again, as we discussed with Fragile X, the process to diagnosis can be challenging a little bit. So let's jump to our next question. I'll hand it over to Maria to kind of do the polling.
All right. So again, open up your polling function, that fourth icon, and the question to you now is, does a normal karyotype rule out a diagnosis of Turner syndrome? So we'll give folks a chance to answer that, and we'll see. I'll give folks about 10, 15 seconds. All right. Getting lots of responses here. I can see them coming in. A few more seconds here. All right, let's see what we've got. So our results of our poll here shows that looks like an overwhelming 70% or better who did respond said that no, that does not rule out a normal karyotype, does not rule it out of the ones that responded. So Katie, or I guess it's Katie who's going to be responding to this?
Yeah. So yeah, you guys are absolutely correct, and I think this is a really important concept to know as providers who are working with families who may be going through the process of evaluation, helping them kind of make sure their understanding of the process is on target. So with Turner syndrome in particular, you can have something called mosaicism. So if you remember back to when we were discussing inheritance patterns, we said that females have 2 X chromosomes typically, and when they are in the process of fertilization, those are kind of divided up. And during that process, you can end up with a situation where some cells have 2 X chromosomes in Turner syndrome, and some cells only have 1. Again, the details of that I think are less relevant, other than to understand that you can end up with a situation where a child has some affected cells in their body and others that are not. And as you might imagine, that can lead to varying degrees of clinical severity and varying degrees of symptoms that look different in each individual child. So when you do that blood test, when you take a sample from their vein, you get, X number of cells, right? And you're looking for the karyotype in those cells, but you're not checking every cell in their body. And so it's certainly possible, and does happen at times, that the cells that they looked at might have 2 X chromosomes, but there are other cells in their body that don't, that only have the 1 X chromosome. And that situation is what we call mosaicism, or being a mosaic. The way that we try to minimize that is by making sure we look at an adequate number of cells. So the kind of standard is to look at 30 different cells when you're doing a typical karyotype. But if you get the negative karyotype back, even if you looked at 30 cells and it still looks normal, but you have enough clinical suspicion, the geneticist will then usually recommend some further testing. And so one of the ways that we can get in that is actually looking at a specialized kind of precursor cell in the skin called a fibroblast. So it would require a biopsy. And checking there, because those precursor cells are present earlier in the development of the embryo, and you're more likely to find kind of the origin of issues in those cells than in your peripheral blood cells. So again, really important just for you guys to help families, be aware that just because the initial testing was negative, if there's a strong enough clinical suspicion, they may need to have more testing to look again. Additionally, if you have a situation where some cells of the body have just the 1 X, you can actually have some cells that have an X and a Y. Even if the child is phenotypically a female, there can be a few cells in the body that actually have both the X and the Y. And in that case, that presence of that Y chromosome actually increases the risk for a particular type of cancer called a gonadoblastoma. Which impacts the gonad, or kind of the primitive ovary, and so you have to remove that organ. And so again, this is just important for families to be aware that this needs to be thoroughly evaluated, because it does impact kind of treatment and management down the line.
All right. Well, this is a place where we decided to break for questions, and I've been looking through the chat box. Looks like a lot of the questions that have been asked are pieces that are going to be addressed as we go further on in the training. Ellen had asked some question about the children diagnosed with autism, are they really Fragile X? And Melissa said that she's actually going to be talking about that. Let's see. Maria from Joliet kind of wanted to know about the red flags that we should be looking for, which I know is part of Melissa's presentation, so just be patient. Melissa's going to get there. And looks like also Katie had asked about the process for finding the unaffected embryos, and Melissa shared that information again. It's called the PGD, Pre-Implantation Genetic Diagnosis. So at this moment, there is one other question Ellen has, wanting to know about the racial makeup of the Fragile X. So is it more affected in whites and less common in blacks, or can you address that, either Melissa or Katie?
This is Melissa. You know, Ellen, I don't have specific statistics for that. I have a theory. Now, obviously, this is just my theory. I would say that the majority of who I encounter tend to be more Caucasians. There is a stronger connection that they're saying with a Jewish heritage, but I also have a theory that part of this, as I've talked about, some people asked about why is there not more awareness. I think there is a lack of awareness, and I think that there potentially is a lack of testing. And I don't know if some of that is because people aren't being tested, that there's a higher predominance in that there's just not a connection. Certainly it's not exclusive to Caucasians. I do have connections with families all across the spectrum of race and things like that. So specific statistics, I do not have that. I probably could look that up and see if I could find more specifics, but I do not have that at this time.
Okay. Based on what I see here, it looks like we've pretty much addressed what questions that we can address now and the ones that you're going to be addressing as the presentation goes on. So I think we'll go ahead and move forward. Thanks, ladies.
Okay, great. So now we're going to dive into a little bit more about the symptoms of both of these disorders and the kind of initial clinical presentation. So when we look at the diagnosis of Fragile X in particular, as Melissa alluded to, it can be a long, frustrating process for families. This graph is put out by the CDC and is just showing us kind of the typical progression of this process. So on average, parents first become concerned about their child's development around 12 months. And then typically by the time they get an evaluation and the delays are confirmed, on average this has happened in about 20 months. And as you can imagine, then there's a bit of a delay till services start around 22 months. And the diagnosis of Fragile X, on average, is happening around 36 months. So as you can see, for families, this is a long process. There's a 2-year gap between the time they become concerned on average and when the diagnosis is made. So it's important for providers and parents to be kind of aware of the subtleties of this process. In Fragile X in particular, the findings on physical exam, which we'll dive into the details of here in a minute, are often less pronounced in early childhood. So the physical features kind of change over time and become more prominent during puberty. So pre-pubertal diagnosis can be tough. But some of the clinical manifestations that we do see early in life, as Melissa mentioned in her story, language delay is something that we often see. Typically it's more expressive than receptive. On average, children with Fragile X are saying their first kind of clear, meaningful word around 20 months, with a range between 2 to 3 years for some, up to 2 to 3 years for some families. And as you can see, that's past our typical kind of age expectation of around 12 months. They also can have motor delays. Their average age of sitting is 10 months, again delayed a bit, and walking not till 20 months. And hypotonia is something that we also see early in childhood, some of the kind of non-specific, but again, something to be aware of for families who are coming to see you. And again, that's why the recommendation include testing even when there's no kind of clear physical features, because the physical features can be so kind of not prominent early on in childhood. As you can see here, Melissa's shared several of her photos with us, and each of these children who are affected by Fragile X look very different, right? This isn't kind of a case where you can look and necessarily see all the features at once. So just important to have a low threshold for concern and make sure that families are getting the evaluation whenever those red flags that Melissa discussed are present. I'm going to hand it over to Melissa, and she's going to dive into a little bit more of the physical features.
I would like to make one comment on the slide that Katie had shown about the average age of diagnosis. We were diagnosed nearly 14 years ago. That average age of diagnosis has not changed in the 14 years since our diagnosis. That tells me that there is a lot of work to be done with this awareness. Hence why when I was offered the opportunity to do this, I jumped at the chance, because I cannot tell you how many families in their journey, which as you can see, 3 years is a long time to be on a journey to get this diagnosis. And there's many that are, outliers. That's the average. There's some like us that are diagnosed at birth, but there's some that are much further beyond that. And I can't tell you how many people have said that their early interventional therapists were instrumental in them receiving their diagnosis. Now, as you know, you can't suggest a test, you can't do things like that, but so many of them said, I happen to have a therapist who said, were you ever tested for Fragile X? What kind of things have been done when they were getting to know them after they had, worked with their child? And that led them to then ask their physician and then get that diagnosis. So kudos to you guys. You are fantastic and really do make a huge difference. And I mean, off the top of my head, I can quickly think of 5 to 6 families who that was how they actually got led to that diagnosis, that even their pediatrician had not suggested it until they went back and asked specifically for that. So kudos to you guys. All right, so now we'll get back. And I did show you on these pictures, this is just the little guy in the stroller is my Matt. He was the cutest little baby. I mean, I could just eat him up. So I had to show him as little. But as you see, as they progress, some features maybe become more prominent. Some are not as clearly defined. So we're going to talk about some of the physical features, and they tend to become more prominent as they age. So kind of the long face, a little bit more prominent ears. Their head circumference tends to be kind of off the chart. I remember when we took Matt to see our Fragile X specialist when he was 2 months of age, and she measured his head, and it was kind of a little break in the tense moment because we were still really overwhelmed, and she measured his head and said his head circumference was large, and then she looked at my husband and she said, well, yours is a little big and you don't have the genetic defect, so maybe it's hereditary from Dad versus the Fragile X. So it was a little levity in that really tense visit. So just thought I would share that. High arch palate. This does cause a lot of feeding difficulties. I was actually very successful in breastfeeding Matt, but a lot of the kids have feeding difficulties because of that high arch palate. They can't get the proper suction and things when they're trying to eat. That also leads to some of the clinical manifestations. With the higher arch palate, they tend to have more ear infections because it doesn't allow for the eustachian tubes to be able to have the right alignment to drain and things like that. So it does put them at risk for more frequent ear infections as well. And then the loose connective tissue, and that's what Katie had referred to before, kind of the hypotonia. They have a lot of laxity in their joints, which makes it more difficult for them to have the mobility and things that they would need. Certainly as they get older, it causes more difficulty with being able to write and being able to hold a pen and hold a fork and do those kind of things. But it leads to a whole host of additional challenges for them.
All right. Oh. Yes.
I think Katie's going to handle this slide.
Clinical manifestations and things that we are watching for in a child who has Fragile X syndrome. So as Melissa mentioned, feeding problems can be tough, not just difficulty with latch and suck-swallow coordination, but also children with Fragile X have an increased risk of pretty significant reflux disease or GERD. So that sometimes needs to be managed medically. We'll also discuss the recurrent ear infections as well as just kind of chronic fluid in the middle ear. So even if it's not infected, they can have excess fluid in their middle ear, which requires kind of close monitoring then of their hearing status with audiology. They do have an increased risk of seizures that typically starts to appear in the second half of the first year if it's going to be present. Not present in everyone, but just an increased risk from the general population. In early childhood, they have increased growth velocities. They tend to be taller, but in the end, their kind of final height is usually lower than average. They also can have a heart finding called a mitral valve prolapse, which is something that can be no big deal, but needs to be monitored for in some cases. And then strabismus, which is misalignment of the eyes. And so that needs to be watched for very closely in early childhood. One other thing that can happen is orthopedic issues. So children with Fragile X can have developmental hip dysplasia or club foot. Again, not present in everyone, but something that is watched for to try to help minimize any problems that may come up. So we're going to dive next into Fragile X syndrome in females. As we discussed, the kind of inheritance of this is complicated, and there can be a very wide range of symptoms, so not every child with Fragile X looks like another child with Fragile X. And this is particularly true in females who have Fragile X syndrome. They can have a lot of variability. And again, that goes back to that idea of being a mosaic, which we talked about with Turner syndrome. In Fragile X syndrome in females, if you remember, females have 2 copies of their X chromosomes. So in every cell in the body, typically one X chromosome is shut off in every female, regardless of Fragile X or not. You don't want 2 copies of the X chromosome acting at the same time because you can then get extra production of protein at a very kind of basic understanding. And so typically one copy is shut off for the most part. Again, there's some more complexity to that, but that's a good kind of big picture way to think about it. And so if it happens that in most of your cells the X chromosome that has the mutation is shut off, then you may not have as significant clinical manifestations as if you had the majority of your cells with the unaffected chromosome shut off. So that's kind of what explains some of the more variability that we see. Just some statistics, up to around 50% of girls with Fragile X syndrome actually can have no impact on their cognitive functioning, and around up to 50% have the kind of characteristic physical findings, which means the other half don't. There can be associated behavioral and emotional problems, including mood lability, depression, and social anxiety, which in some cases in females may be the presenting symptom because they may not have the physical characteristics or cognitive impairment or some of the other things we've talked about. And so behavioral and emotional problems can actually be kind of the initial reason that someone is seeking evaluation.
So I'm going to talk a little bit about the Fragile X premutation carrier-associated disorders. A lot of times there's confusion in terminology where they will say that even though a female has the repeat level of being a full mutation, like my son would have, that they're carriers because they don't manifest the classic symptoms of the delays across the continuum that boys typically do. However, when you talk about a carrier, you're really talking more about that premutation state, so that range of that 55 to 199 technically. So when we talked about this earlier, there's the 2 carrier-associated disorders, so the FACS-TAS, and as I mentioned before, it's kind of a cross between a Parkinson's and a dementia. It's neurodegenerative, usually manifests around the age of about 50, is more common in carrier men than carrier females. And it looks very similar to Parkinson's, and that's what's so tricky about Fragile X. A lot of its things look very similar to other disorders. The Fragile X syndrome looks similar to autism. This looks similar to Parkinson's. The biggest difference with this is that when they have tremors, they don't have tremors at rest. They have tremors on intention, which means when they go to reach for something, the tremors are there, but they don't typically have the tremors at rest. The other one is the factoid, which we kind of talked about a little bit before as well. This is something when a female has menopause prior to the age of 40. They may have ovarian dysfunction, infertility. This occurs in approximately 20 to 28% of premutation females. So someone who has an unknown cause of premature ovarian insufficiency has a 1 in 50 chance of having that be related to being a Fragile X premutation carrier.
All right, so for the sake of time, we're running a little low on time, so I'm going to move kind of quickly through this stuff. So let's feel free, though, to save some questions for the end if folks want to stick around. So when we think about the clinical manifestations of Turner syndrome, again, every child is a little bit different, but there are some classical physical features that we're going to go through, and these two photos kind of illustrate several of them, and we'll dive into the details of those in a second. So I mentioned that it can be diagnosed prenatally, and so this is an ultrasound of a child with Turner syndrome, and the things that we see here that point to a diagnosis of Turner syndrome is subcutaneous edema or swelling under the skin. So this white circle here is the baby's skull. Here's the baby's brain, and then this fainter white line is the skin, and so you see swelling under the skin. You also see under the skin this large fluid-filled sac here called a cystic hygroma, and the presence of a cystic hygroma is concerning for Turner syndrome. You can also see abnormalities on prenatal screening, so most pregnant women are offered what's called a quad screen or a triple screen, which is looking for chromosomal abnormalities, and you can find abnormalities on that screening test as well that can lead to a diagnosis of Turner syndrome. Once the child is born, some of the physical features that you may see are kind of related to what we saw in the ultrasound. So this swelling here at the bottom of the baby's head, at the base of her head and her neck, is a remnant of that cystic hygroma. And so you can see kind of swelling there, as well as swelling of the hands and feet. This is related to abnormalities in the lymphatic system, but this classic finding of what's called congenital lymphedema, or swelling of the hands and feet, is very concerning for Turner syndrome. Once children get a little bit older, you can see some other manifestations. So one of the main features that's present in just about every child with Turner syndrome is short stature. And in fact, that's one of the red flags for Turner syndrome and raises the concern for testing. A lot of children also have a high arched palate, similar to what we discussed in Fragile X. The presence of what's called a shield chest, or a very broad chest with widely spaced nipples. You can see a low posterior hairline, a wide carrying angle of the arm, so the elbow's angle is kind of wider than typical. A short fourth metacarpal in the finger, some abnormalities with the ear, and then this webbing of the neck is another one that you will hear talked a lot about. So children with Turner syndrome typically have a webbed neck, and we'll see some photos of that as well. The decreased growth velocity, this kind of main feature up here, usually starts to present around 18 months of age. So something to be aware of in the children that you're working with in early intervention. So here's a cartoon drawing of some of the features. So you see the web neck, kind of this idea that instead of going straight down, the skin on the neck is a little bit broader. They also can have a number of medical kind of complications. So there's a number of different cardiac malformations that can be found, as well as some difficulties with reproduction, and we'll briefly touch on those. Here's the low set hairline that we mentioned, and then the abnormality of the fingernail, where the fingernails are excessively hyperconvex, so they're kind of lifted up, is something else you can see in Turner syndrome. So sensory neural hearing loss is a concern. It's thought to be progressive. The numbers vary quite a bit, but it can be seen in a number of girls with Turner syndrome. This here is showing one of those cardiac manifestations that I was mentioning called coarctation. So that's the idea that the aorta is squeezed narrowly at one point, so you don't get appropriate blood flow. This can be quite significant and needs to be actively kind of monitored for in children who've been diagnosed with Turner syndrome. And one of the other main manifestations is what's called a streak ovary. So meaning they don't have a fully formed ovary, and this picture here is kind of showing that you just have a streak of tissue. It's kind of a remnant of what would have been an ovary. And so they often, though not always, are unable to ovulate. You can have a number of other cardiac manifestations, and so an echocardiogram, or a full kind of radiology view of the heart is a mandatory part of the evaluation for a child diagnosed with Turner syndrome. So this graph is showing the kind of projected height of girls with Turner syndrome, both who have been treated and those who haven't been treated with growth hormone. So thinking about growth hormone use in Turner syndrome is one of the big clinical questions that comes up, because without treatment, girls with Turner syndrome end up being quite a bit shorter than the general population. And so this dark line here is kind of the projected height for a child who doesn't receive treatment, whereas these dotted lines up here are showing in this study the ultimate height achieved in girls who were treated. So it's something that a lot of families think about, but there's a definitely risk-benefit analysis to be done with the use of growth hormone in anybody, because it has some risks, including diabetes, hypertension, and cardiac complications, and it's also exceptionally expensive, in the order of tens of thousands of dollars, which may or may not be covered by insurance. And again, what you're looking for is a height there, and so it's important to think about, for the child, like what is the benefit of doing this versus the risk, and that certainly needs to be managed on an individual basis with a provider who has a lot of experience, typically an endocrinologist, in thinking about those risks and benefits. Some of the other features are eye manifestation, so a lot of them have strabismus, or again that misalignment of the eye. They also can have recurrent otitis, again the idea of the high arched palate that we talked about, as well as hypothyroid, which needs to be monitored and managed closely. You can see diabetes, you can see different types of inflammatory bowel disease, different types of kidney problems, so there's a whole range of medical complications that go along with Turner syndrome and need to be actively managed and monitored. And so with our remaining time, we want to dive into a little bit about the kind of developmental trajectory of each of these disorders and how to help support families. So Melissa's going to start with talking briefly about that for Fragile X syndrome.
So I quickly put on here some of the people had asked about things that would make them stand out. Fragile X syndrome has a whole host of strengths as well. Their memory, like a steel trap. Don't tell them something and not own up to it. They're great imitators, which makes them very different from the autism population. Tremendous sense of humor. They're very social. Although it causes a lot of anxiety, they do seek that social behavior. Their receptive language is much greater than their expressive, and they're very intuitive people and have great reads. Their challenges are their auditory processing. If you ask them a lot of direct questioning, it leads to more anxiety and difficult for them to do. Eye contact is very difficult for them. Once they kind of don't feel that threat and gain trust, they will start to initiate their own eye contact. Sensory processing is very difficult. It leads to hyperarousal. That could be a whole talk in itself. I will have links coming up in one of the talks that you guys can look more information about this as well. A lot of anxiety. They have motor planning difficulties, cognitive delays, the expressive language we've already mentioned a couple of times. Effective strategies, that peer model, when I said they're so social, having a peer model is a great motivator for them. A sensory diet for those of you that are OTs, starting this on kids young, great strategy. I wish I had started it sooner. I wish I had the knowledge back then that I have now. Visual schedules help some kids. For us, it causes more anxiety. A side dialogue is where you kind of talk about things instead of talking at them. You kind of maybe even talk to yourself to motivate them. Working alongside versus across from them, that doesn't cause as much anxiety. It's not as much of a threat. Social stories, video modeling, and then teach to their unique learning style. Again, I will show you, I have a link coming up that shows you educational supports. So this top link that's on here, the supports for younger children, this is a great resource that's on the National Fragile X Foundation website. They have educational strategies and things that go from birth up through high school. It's really important to focus on supporting their everyday routines and their natural environments. And then this consensus document, this bottom resource, I cannot tell you how much I refer to this. This is experts from all across the continuum, speech therapists, physicians, OTs, educational people, psychologists, that have come together and created these documents that touch all areas across the continuum to help you have that resource as if you have these experts in your home to be able to know how to address the concerns. Again, educational services, this chart I'm not going to go through. I put the link at the bottom here again about educational interventions that you can do that go across the continuum. That's going to be something I really think you would like to spend some time on.
And just briefly to highlight the number of different kind of comorbidities that can present in children with Fragile X syndrome. So they can be diagnosed with ADHD, they can be diagnosed with attention, or excuse me, with anxiety, with depression, and then we'll discuss the autism piece really quickly here. So just to know that the diagnosis of Fragile X syndrome raises the risk of these other conditions, and they need to be screened for and watched for and aggressively treated with behavior management, counseling, or medications as needed.
So a lot of people have asked about the similarities between autism and Fragile X. As I mentioned before, 30% of people with the full mutation meet the criteria for autism, and 20 to 30% meet the criteria for the PDD-NOS. Fragile X syndrome currently is only responsible for about 2 to 6% of people diagnosed with autism. Again, I have a theory. A lot of that is because there's not testing. And I think if people were tested more frequently and more often, I think that number would increase. And they both can have very stereotyped behaviors. So this is something I think a lot of you have asked about. Why does Fragile X syndrome look like autism, but it's not? There are similarities that even the role and function of the FMRP that caught in the brain when it's not there in the Fragile X brain, that research has even shown in the last couple of years that even in the autism brain, that protein even being present is not functioning in the way that it should. The differences that children with Fragile X are very social. They thrive and seek that peer interaction. They're tremendous imitators, good and bad, so you want to give them the positive environment that you want. They have an absence or dramatically decreased production of the FMRP, and that Fragile X is genetically diagnosed and defined disorder, where autism is a behaviorally defined disorder with many known and unknown causes.
So when we think about the kind of developmental projection for a child with Turner syndrome, most patients with Turner syndrome have normal intelligence, though about 10% can have developmental delays. Similarly, ADHD can be relatively common, and anxiety, so important to be on the lookout for those and thinking about those. Impaired peer relationships is one of the features that we see, in that it probably results from difficulty with nonverbal learning. So girls with Turner syndrome are at a very high risk for what's called a nonverbal learning disorder. That impacts your ability to think about things in visual spatial concepts, relate objects to each other, manipulate objects in your mind, see differences between objects, do math problems. So nonverbal processing of information, and that impacts on your social functioning in terms of your ability to, read facial expressions, understand social cues, body language, things like that. So that nonverbal learning disorder is very prevalent and something that's really important to be aware of. This study is just kind of a graph showing that difference. Unfortunately, we're running short on time, so I'm not going to dive into a ton of detail, but showing that compared to their mothers, girls with Turner syndrome have great verbal skills, but much more difficulty with nonverbal intelligence. And so that strength in verbal language is an important skill to build to, but important to be aware that most children who have a nonverbal learning disorder are going to need an IEP or other school-based supports to help make sure that their learning is not hindered in any way. And then as providers, being sure you help families know that they need to watch and screen for some of those other anxiety, ADHD, and other kind of emotional and peer relations that can be challenging for girls who have Turner syndrome. And as we're finishing up here with the last couple minutes, we just wanted to take a moment to emphasize the ways that families can be supported through the use of kind of national organizations. So Melissa's going to finish up with that really quickly.
So, as I mentioned, I am a leader of the Greater Chicago Community Support Network. So I live in the Chicago suburbs. I also am the leader of the Central Region, so I cover several states within the Midwest as well, through the National Fragile X Foundation. this was instrumental in my journey, that I found it was so reassuring to find other families who were in this process. If you have clients that you're working with that have you know, a diagnosis of Fragile X or looking for some support, finding the national organizations, there typically is always some sort of support component to those. If you have someone with Fragile X, certainly send them my way. I did put my email just at the bottom of the chat line, that if somebody needs to contact me, to you know, needs help with getting someone connected or things like that, certainly reach out to me. I'm happy to help. But the National Fragile X Foundation for us has been instrumental in changing my perspective of this being a big challenge to learning how to see the silver lining in this. And it really has been a blessing in our life.
And similarly, there's great organizations for Turner Syndrome out there as well, which we highlighted, the Turner Syndrome Society of the United States and the Turner Syndrome Foundation. So great resources to get your families plugged in with as well.
Right. I just wanted to make a note that Melissa and Katie have been really fantastic about responding to the questions on the chat. And as you can see, we are running to the end of our time, so we'll let Susan wrap it up. And thank you all for participating.